Welcome, everyone, and happy Friday. I'm Kelly Emeru. I'm Vice President for the Center for Professional Strategic Alliances with the National Minority Equality Forum. I'm happy and excited to be sitting in for Brandon Garrett, who's taking some much needed time off. I'm sure wherever he is, he's thinking about us, but enjoying himself. So kicking things off. Today we're actually diving into a critical issue that demands our attention, kidney care disparities. The reality is staggering. I know I'm preaching to the choir, so I don't need to give you any of the statistics, but this program today is going to be looking for innovative solutions. How do we have flexible payment models and legislative path that moves us forward and tackles the disparities and the gaps that currently exist head on. So the program or the webinar is called Advancing Upstream Kidney Care, a legislative solution to reduce disparities, improve outcomes, and lower costs. So to guide us through this conversation, I'm excited to hand things over to a moderator for the day, Holly Bode. She's Vice President of Government Affairs and Chief Advocacy Officer at the American Kidney Fund. And we at the National Minority Equality Forum work closely with AKF and are partnered in a number of initiatives. So looking forward to this conversation. Holly, handing it off to you.
Thank you, Claudia. I am as Holly Bode, and so I am the American Kidney Fund Chief Advocacy Officer. And as Claudia said, we're here today to talk about kidney disease and how it affects 1 in 7 people in the United States, with millions more people at risk. And that's why we need to focus on upstream kidney care, meaning how do we focus on preventing kidney disease in the first place, early diagnosis and treatment once someone has kidney disease. Kidney disease, especially in its later stages, has a disproportionate impact on communities of color. So, for example, the latest stage or the final stage of kidney disease is stage 5, and that's end stage kidney disease. That's when someone has to go on dialysis or get a kidney transplant. And 30% of people who are on dialysis are Black or African American, and they're only 13% of the population. So it is a wildly disproportionate impact. And similar statistics exist for other communities, Latino and Asian American communities. And so it's a disease, especially in its later stages, that has a hugely disproportionate impact on communities of color. So last year, the American Kidney Fund released a report called Healthy Workforces, Sustainable Futures: Why Employers Should Invest in Early Kidney Care, in partnership with the National Alliance of Healthcare Purchaser Coalitions. So this report examined the impact of chronic kidney disease on the workforce, on the U.S. workforce, and identifies solutions that employers can implement to keep employees healthier, more productive, all while reducing healthcare costs. So this report focuses on, a large part of our economy that has skin in the game for preventing and treating kidney disease, and that's employers. There have been numerous challenges contributing to the lack of early detection and treatment of CKD, including limited public awareness of risk factors, lack of widespread screening, knowledge gaps among providers, which is a problem that we are really, really grappling with. So many of the people, American Kidney Fund is a patient-focused organization, and we have countless people coming to us once they're diagnosed who said their doctor didn't really even screen them for kidney disease. And once they did, they downplayed it if they were at their 5 stages of kidney disease. And we had so many people come to us and say, oh yeah, my doctor says I'm at stage 3 kidney disease, but I don't need to worry about it. So there's an enormous amount of work that needs to be done to help educate not just patients, but providers about kidney disease. So, and until recently, the treatment landscape for earlier stages of kidney disease was also pretty limited. There really weren't that many treatments available, except for the most part, some lifestyle changes or better management of your hypertension or diabetes. But today, we do have treatments that actually treat chronic kidney disease, like SGLT2 inhibitors and GLP-1s, actually, that can slow or stop the progression of CKD. And employers have also historically lacked appropriate incentives to cover upstream care, given that by law, most people qualify for Medicare once they go on dialysis, regardless of age. And so there's just not the economic incentive there necessarily for employers to invest in keeping people off dialysis, because once they're on dialysis, they're on Medicare. They're not on their employer plan anymore. So we're really excited to announce that in late July, legislation was introduced by Congressman Joe Wilson, a Republican from South Carolina, called the Prevent ESRD Act. And this legislation creates a demonstration program to share Medicare savings. And so basically, if you slow the progression or stop the progression to kidney disease or to, dialysis, Medicare saves money. And so this demonstration would share that Medicare savings or some of that Medicare savings with employers who can demonstrate they kept people off dialysis. So we're extremely excited about this legislation. Again, it's called Prevent ESRD Act, HR 9891. And once Congress is back in session in September, and there are 20 other organizations who supported the introduction of this legislation, will be doing everything we can to get more co-sponsors on this legislation. So now I would like to introduce our panelists, and I will introduce them in the order in which they will speak today. So Teresa Caldron is a patient ambassador with the American Kidney Fund. She is a healthcare professional and patient advocate with over 2 decades of clinical experience. She has been a registered nurse in Oklahoma for more than 15 years. But her career took a turn when she transitioned from healthcare provider to patient after being diagnosed with a rare autoimmune disease that led to acute kidney failure. Following a successful transplant in 2020, Teresa has dedicated her expertise to advocating for early detection and prevention strategies of kidney disease. She's become a frequent voice in the kidney community, and she does so much work with the American Kidney Fund. We're so grateful to her, collaborating with state and federal lawmakers to champion legislation like the one I just mentioned. The Prevent ESRD Act. Next, we have Melissa Bartlett. She's the Senior Vice President of Health Policy for ERIC. She leads the development of ERIC's health policy and advocacy for its legislative and regulatory priorities at the federal, state, and local levels. She supports ERIC member companies in advancing policies impacting all aspects of employer-sponsored health coverage, including the taxation of benefits, healthcare costs, quality, safety, and access, as well as laws and regulations affecting how healthcare benefits are administered on a nationwide basis. Neil Masia is the CEO of the Health Capital Group. Neil's an economist and health policy expert whose work focuses on the financial and systemic drivers of better healthcare outcomes. He previously served as chief economist for Pfizer and now teaches as an adjunct professor at Columbia University. His recent research explores, in the kidney space, explores the impact of kidney disease and the potential for Medicare savings and savings to employers for investment in upstream kidney care. Neil was the author of the report I mentioned earlier, Healthy Workforces, Sustainable Futures. And so with that, I am going to turn this over to Teresa, who is going to talk to us about her personal experience with kidney disease and as an employee when she was a full-time employee when she was diagnosed. Teresa?
Hi, Holly. Thank you so much, you guys, for having me here. I am happy to share my story. I'll start off, as Holly said, I was diagnosed with a rare autoimmune disease back in 2009. At the time, I was a registered nurse at a major hospital for a health system here in just outside of Tulsa, Oklahoma. And I ended up, over a period of time, going from full-time to part-time, dealing with my illness. Ultimately, I ended up as a patient in my own hospital in acute kidney failure. It took over 2 years for me to get a diagnosis. And as Holly was saying, things get downplayed. A lot of my signs for kidney disease and progressive kidney disease were kind of just downplayed until I did end up in the ER in acute kidney failure. The irony of this whole thing is I worked for a hospital. And some of the things I thought of as I was going through all this and why it took so long, and I didn't have really any early signs. I kind of just bowling balled through the whole process of ending up in acute kidney failure. And speaking to what this bill is all about, this is huge. There are so many ways this could help not only just get for everyone earlier diagnosis, earlier looking at the kidneys, but also I think it has the potential to affect a huge group of our minority patients and those that have a lot less contact with the medical community. My story is kind of, is when I was hired as a new employee, you have employee health in the hospitals. And, my feeling now is employee health, is not for the employees, even though it's labeled that. I feel like it's for the entity hiring you to make sure that, you're going to be able to carry out the duties that they're going to ask of you without ending up with a workman's comp claim. That's kind of how I personally feel. But they do things like drug testing and other health tests. And one of the easiest and most simple things you can do to test the kidneys and to look at super early signs that something is going wrong is a urine dipstick. It's like a $2 test. You can even buy the test strips on Amazon for that matter. And if they're already doing a urine test, my thoughts are how easy would it be to just do one of those and let people know, hey, there's blood in your urine, or you've got really high protein in your urine, or something is going on, you need to get this looked at. And, it's a very simple thing. It does still put it back in that employee's pocket to do something about it, but most people don't ever know that that is something that is going on in their body. You can have blood in your urine, it's microscopic, you don't see it, but that's a huge sign that something's going on with your kidneys. Excuse me. So that's kind of why, I'm here. I could have, with my disease and my process, had I got an earlier diagnosis of why I was having kidney failure and that I was in kidney failure, I may have avoided a transplant and dialysis altogether. And, I think the world, and especially the healthcare world, kind of views dialysis, especially insurance companies, as a cure or just a treatment, and it really isn't. It's just a bridge. It's a bridge to either getting a transplant or end of life. Dialysis doesn't cure anything. It doesn't fix anything. The side effects of it cause a lot more problems too. So ultimately, if we could keep people off dialysis, and dollar signs are huge in lawmaking and for any insurance, Medicare, all of that, dollar signs talk. And just for an example, my dialysis, I did peritoneal dialysis. I did it at home. I know that my insurance, which I had a private insurance, but then I also had Medicare for being on dialysis. But I know the bill for every single night, and I did it 7 nights a week. Every day it was over $1,500 a day that was billed, and that adds up to, close to, what is it, $50,000 a month, basically. Don't grade me on my math. But if you can keep someone off of dialysis, that is, when you figure, that was just one person. And the amount of people on dialysis is huge. And that cost that it's costing Medicare, not just Medicare, but employers. For me, when I had to quit work, they had to train someone else to take my place. They had to pay me my sick time. So the cost to an employer for me being off work was a lot more than what it would cost to do that $2 test once in a while. Most big corporations have to have testing done or do things for OSHA, once a year or something like that. There's no reason why they couldn't offer this test during that time for, like I said, they could probably even get cheaper than $2. Ultimately, that could save a company so much money in just employee costs. And then if they have the benefit of getting some Medicare kickbacks for that, or helping them with those costs, that would be huge. But what it's really huge for is I think of the people that worked at the hospital in some of the non-patient care areas, janitorial services, in our cafeteria. They worked in laundry, amazing people, and they were hard workers. But culturally, a lot of them don't go to doctors that often, or they don't even want to. That's just part of their culture. And if we could get this for them, and these are the people that have the highest risk for kidney disease. So getting them this early testing could be huge. I mean, it could save lives ultimately. So that's why I feel like this is such a big deal. The money is there. I mean, you can look at the dollar signs and clearly see that this would be a huge benefit and not a hard thing to do. So that's kind of where I stand with this, and happy to answer any questions at the end, but I won't keep boring you with my story. But that's why I'm passionate about this, is not just the money part of it, but for me, it's what it could do for patients and what it could do to bring people who aren't getting the healthcare they need in those underserved communities, bring them to the table so that they can get diagnosed quicker and hopefully have a better outcome.
Thank you so much, Teresa. We really appreciate your willingness to always share your story. It means so much, I think, and it just brings it all home that, you know, this is a very personal thing happening to a lot of people. So thank you for that.
Thank you.
I'll turn it over to Melissa from ERIC, the ERISA Industry Committee, to talk about their perspective on these issues.
Thanks,
Melissa?
Holly. And thanks for having me today. I'm very honored to be part of this panel. And I hate having to go after Teresa because she's so eloquent in her presentation, but I'll try my best. So I'm Melissa Bartlett. I'm the Senior Vice President of Health Policy at the ERISA Industry Committee. We're a national trade association that advocates on behalf of large employers regarding health, retirement, and compensation policies at the federal, state, and local levels. Our member companies employ people in every state and are really the backbone of the employer-sponsored insurance system that provides health benefits to over 160 million American workers and their families. This number shows that employers are not just passive participants in the system, that they are the primary financiers. And under ERISA, many large employers choose to self-insure, meaning employers directly pay for medical claims and fees out of current company funds that are ultimately a part of an employee's total compensation. And sometimes an employer does choose to be fully insured, meaning the employer pays a fixed premium to a third-party commercial insurance carrier that would cover the medical claims. So our member companies are all self-funded, large health benefit plans that are offered by these large employers. ERIC's our member companies have a very strong interest in prevention and health screening overall because of the direct connection between workforce health and organizational performance and the return on investment of early detection and intervention. Early detection not only improves clinical outcomes for employees, but also reduces insurance claims and disability costs, creating a clear financial incentive for companies to prioritize these initiatives. But beyond cost containment, prevention and screening programs are increasingly viewed as part of a broader strategy by employers to enhance employee well-being, engagement, and retention. Workers are more likely to feel valued when their employer actively supports their health, which can improve morale and reduce turnover. Many large organizations now offer on-site screenings and wellness incentives and digital health tools to make preventive care more accessible and convenient. These efforts also align with the shift towards value-based healthcare, where outcomes, not just services, matter. And in this context, prevention becomes a practical and strategic investment for employers, helping them build a healthier, more resilient workforce while managing long-term risks. ERIC has successfully advocated for a host of policy changes that make these kinds of efforts possible, including the new legislation that Holly referenced at the start of this presentation. That bill would create a voluntary kidney care model. This voluntary kidney care model would allow health insurance plans and employers, here, the employer-sponsor plan, to share in the savings that they create for Medicare by preventing or delaying ESRD and help promote earlier screening and treatment for kidney disease. 35.5 million Americans are suffering from CKD, and 831,000 are suffering from ESRD. CKD impacts 11 million workers, or nearly 7.4% of the total US workforce. Workers in the later stages of CKD, stages 3 to 5, are responsible for 8% of annual employer healthcare costs. That's equivalent to $107 billion in annual healthcare spending, plus an additional $30 billion, as Holly mentioned, as Teresa mentioned, in lost productivity each year for American businesses. Preventing late-stage kidney disease could yield an estimated $9 billion in annual Medicare savings and $35 billion in annual savings for employers. More importantly, it would transform kidney care and improve the lives of millions of Americans. And that is why Eric strongly supports the legislation that Holly mentioned at the start. And we look forward to working alongside the other, I guess, 19 organizations that are trying to drive this through Congress. Thank you.
Thank you, Melissa. Thanks so much for the employer perspective. And so, Neil, your research has explored the economic impact of kidney disease on patients, the research that you've done with our kidney community, and it's really focused on the benefits of preventing kidney disease progression, and not just, the economic benefits, but, just the benefits to the population and to the human experience in general. So could you walk through some of your work and what these findings mean in terms of the unmet needs related to kidney disease prevention and treatment?
Sure. Thanks for having me, Holly, and National Minority Health Forum. And this has been a great partnership trying to understand the rationale for why employers should prioritize investments in kidney care. Like everything, there's always trade-offs. And so my work in this area, like should we invest in this versus heart disease or other areas, we'd always love to do everything. But my work has been to kind of quantify the size of the opportunity, to highlight that for employers in a very concrete way. And so in the report that I know is on your website, we wanted to calculate a couple of things. One is the direct healthcare cost, and you heard reference to the Medicare savings. That's from a prior study that I did, the 35 billion number, but there has been not as much research on the opportunity for employers. And so given the very broad number of people that we estimate have kidney disease, whether it's diagnosed or undiagnosed, but are still working, we wanted to really estimate the size of a couple of things. One, that the healthcare costs. Two, the bigger number, which is productivity loss, turnover costs. And then to break both those down basically by type of worker. So if you think about differences, some of which were already referenced in race, but also on location, like where you live. People in rural areas often live very far away from a nephrologist. And then to quantify how earlier intervention in kidney disease might impact employer cost in, let's say, the next 5 to 10 years, in both reduced spending and productivity, which is something that, I kind of take a broad approach. So there are some pretty big differences. Those 150 million people in the workforce, give or take, we estimate about 11 million of them, 7.5%, are living with kidney disease. We broke that down by subcategory and by stage. So for example, we know the prevalence is higher among women than men for kidney disease. So women are 47% of the workforce. It's 55% of the kidney disease having workforce. And, so it's like that 7.5% is really like 8.6% of female workers are estimated to have kidney disease, only about 6.2% of male workers. Big difference between, especially in the Black population, the overall sort of working Black population, we think 19.5% prevalence for those who are working, as opposed to a lower amount, obviously, for white workers and other groups. There's a big difference based on education. We know that less educated workers have, so for those who have greater than a high school education, it's a 13. I should say it's a higher prevalence for those with less than a high school education or with only a high school education. And then huge difference by income. So lower income workers have over a 14% incidence. So if you think about trying to keep a factory working or keep the hospital staffed, which relies heavily on lots of lower income workers, you just have a big problem. And also big geographic variation. For example, like the South, the Deep South has a very high prevalence. Places like New York, maybe a little lower, San Francisco. So we hard coded those in to do estimates at the national level but in the report, you'd see lots of illustrations and examples. So what we did to calculate our estimates was that we really only started counting an estimate in stage 3 of CKD, which, many people in stage 1 and 2, to Teresa's point earlier, don't even know that they have the disease. So it's not easy to calculate their costs. But starting in stage 3, we think there are about 1.6 million workers who have advanced to CKD stage 3. And then 4 and 5 are smaller numbers because usually when a person gets to stage 4, stage 5, they start to leave the workforce. And what we did was we looked at the absentee rate within each stage. So for example, how often do they actually miss work? For stage 3, it's about 6%. By the time you get to stage 5, it's 13%. And then we looked at the cost of that based on their average wages. So when you add up the absenteeism costs for the nearly 2 million workers with stage 3 or above CKD, we get a number of $7.5 billion per year just in absenteeism costs. The much bigger number is the presenteeism cost. In other words, what's the productivity decline? And we pulled estimates for this out of the literature by stage, and you get a presenteeism rate. In other words, just think of it as a productivity decline of 19% for stage 3. So there's 19% less productive, 28% for stage 4, and so forth. Those add up to big dollar numbers. It comes to a $22.4 billion estimate. So if you add these together, employers are basically funding the care or funding the productivity costs to the tune of at least $30 billion a year in lost productivity. Now, of course, when you start to look at the healthcare costs, the numbers really add up. And when we take a similar methodology, stage by stage, to those 2 million or so patients, we wind up estimating that if you could keep all of the patients in stage 2, so that's a dream, obviously. But if you could keep all of those stage 3 and above patients in stage 2 with earlier intervention or diagnosis, you would take $107 billion of cost that those 2 million patients cost today. You would save about 3/4 of that. That's the difference between getting to the later stage and getting to the earlier stage. So there's $72 billion of savings on the table each and every year, which is a very obviously significant number. And that doesn't include the ESRD costs for patients that have now left the workforce, generally gone on, are transitioning to Medicare, but the employers have an obligation in the transition period that we're not even calculating there. So we see a very, very large estimate of what the savings can be. And it's just you just don't see that many $100 billion opportunities for employers to invest in what can often be, to Teresa's point, like pretty low cost of investment. And I do think that in most cases, it's simply a question of just not understanding the potential upside, and the education that this group and other groups can do to help a CFO of a big company understand that a huge portion of his workforce is going to turn over every year because they're going to leave the workforce because they get too sick and need a kidney transplant. It seems like the most obvious message in the world, but until you put dollars and cents to it, it's just hard to know where to prioritize it. So I guess as an economist looking at this, I'm arguing for, I haven't found yet something else that should be higher on the list than some very straightforward things that you can do to these patients that you're going to find in stage 1 and stage 2, because there are things you can do to better manage those patients. So I'll stop there, Holly, but obviously I'm happy to answer any questions.
Yes, thank you so much, Neil. Thank you for being such a passionate advocate for kidney disease. It's interesting when you work in the kidney space that people who didn't know much, and I'm not suggesting that Neil didn't know very much about kidney disease, but once people start learning more about kidney disease, it's amazing how passionate people become about the disease, and how people just want to know more and want to get engaged in helping more people get diagnosed. Because 40% of people who are on dialysis crash into dialysis, which means they didn't even know they had kidney disease. And so in a country that I think thinks of itself certainly as having a good healthcare system, that is a pretty shameful statistic. And I think once you learn that, upstream care in kidney disease is actually pretty affordable and accessible, and it should be more readily available to people. And so I think once people learn that, they become very engaged on this issue. So I have a question for Teresa, and I have a couple questions for the panelists, but I want to encourage people. I see we've got a few questions already from the audience, but if you have any questions you'd like to ask, I encourage you to put them in the question box that will be on your screen. So for Teresa, thinking about some of the things that Melissa and Neil mentioned and reflecting on your own journey, as well as conversations you've had with many others living with kidney disease, how do you think patients could feel more supportive in the workplace when it comes to kidney care and prioritizing early interventions? Teresa, you're on mute.
Sorry. I'm so sorry. Better.
Happens to the best of us at all times.
I think that's huge. And it truly isn't. I mean, I know we're here and we focus on kidney disease, but those urine tests can pick up lots of other things that could be going on also. And I think one of the hugest things for productivity and kind of maybe employee loyalty is we want to feel valued. You want to feel valued by the company that you work for. You want to feel like they care. And something as simple as that, when they show that they're interested in your health and what's going on, and they want to make sure that you're staying healthy, I think that's huge for just employee loyalty. And I'm sure it would help with productivity when someone's happy to work at a place where they feel valued. For me, it could have changed my life. Had I been diagnosed a lot earlier, like I said, I could have possibly avoided a kidney transplant. And my life has gone a complete 180 from how I always thought it would go. Not that it's a bad thing. I think that something good comes out of everything bad. And the fact that I'm here doing this is proof of that. But I no longer have a career working as an RN. Part of that is my choice, but part of it is I kept getting sick. I couldn't work in patient care, and I'm not a person to sit at a desk, so that kind of wasn't an option for me. I'm not saying that's a bad thing. I have found my way through it and been blessed in so many ways, but it just changes your life completely and takes people away from careers that they were possibly really good at. And that they make a difference in. So it's a huge effect across the board.
Thanks, Teresa. And I know in previous conversations, one of the things you mentioned is not the impact of kidney disease and say kidney failure, not just on the patient themselves, but on their families and on their caregivers. And I think
yes,
you mentioned the impact it had on your husband's employment.
Right. I did. You're right. I forgot about that. My husband, that's how we met. He's a nurse as well. So, and we had 4 young kids. So, he ended up having to take days off to either help with the kids because I was in the hospital or I was sick or I had doctor's appointments. And his mind wasn't completely at work. It was on what was going on at home and all the adjustments we had to make, the financial struggles because we lost an income. So it affected everybody. It affected him. It affected the people he worked with in his area, my kids, my family that was pitching in to help as much as they could. So it's kind of like it takes a village. Well, it affects the whole village that you have when you have a chronic illness like this.
Thank you. Melissa, we have talked, today about what employers can do with their own benefit programs. But many of these policies and many of these ideas work best when they're paired with supportive federal policies. I know we've talked about the legislation that was introduced, HR 9891, the Prevent ESRD Act. But what are beyond that, or even talking about that, what are some things that the federal government can do to support more investment in kidney disease for employers?
Yeah, thanks, Holly. I think some of the things I mentioned that we've supported and continue to support, again, aren't specific to just, kidney ESRD progression or CKD screenings, but in general around getting prevention and screenings out to workers in a way that makes sense so that workers don't have to take time away from work to seek out these screenings. Many of the large employers, the ones that have a nationwide workforce, offer on-site clinics. And with these on-site clinics, it's your primary care is right there where you're employed, and both you and your family can go there to get a whole host of services, including prevention and screenings through that. So it's convenient for the worker. And one of the things, for example, we are advocating for and have been for quite some time now is to really modernize or address the flexibilities that are necessary so that workers who have a high deductible plan and have a HSA can really maximize those HSA dollars in using those on-site service clinics. So it can be, pretty much first dollar coverage free for you too, to just pop down there and do the urine test, like Teresa was saying. So I think employers have a lot of opportunities like that to sort of think outside the box and educate their workforce about the different programs that are available to them, and really try to encourage them to utilize things like the on-site clinics or like screenings and tests to really promote, again, all of the things like Teresa was saying. You want the workers not to have to take off work for things. So if you can make it convenient to them, if you can make it cost free to them, even better. And if you can keep folks from losing productivity but also retaining that workforce, right? These are all important measures for employers to consider when they facilitate different models of delivery of care.
Thanks, Melissa. Really appreciate that. So Neil, you've already, worked with this community to do 2 big studies on upstream care and the financial impact on the Medicare program and on employers. What other areas do you think in this space would benefit from more economic analysis? Like if you were going to do another study, what do you think that would be, or what would you like it to be? Neil, you're also muted.
Good. It gave me a little time to think. It's a great question. I can think of a couple of areas that I think when I've gone looking for, basic stuff that would help either inform policymakers or employers, that just doesn't seem to be there. One is really just about access. So, it'd be great if Teresa's plan of everybody getting tested all the time came true. But what if the person lives in, Enid, Oklahoma, and I don't know, I'm just making up a city because I don't know anything about Oklahoma, but I know you're in Oklahoma. What if they're in the middle of nowhere and they really can't get an appointment for 6 months with a nephrologist? Uh, you know, I don't know how often I know anecdotally it's a problem. I don't know how to quantify that problem, but it's something that lends itself to research, right? So it's kind of like, how can we do a better job of understanding the urban, rural, the different challenges in those 2 places? Because it's really very different communities doing different jobs, different age profiles. In the rural areas, you got an older population. Might have more difficulty doing that 2-hour trip to the nearest whatever. And so I think there's plenty out there that illustrates that, but I haven't seen a really good kind of succinct story that would or succinct analysis. So that's one area. I do think that the certainly the incredible growth of the obesity drugs and the GLP-1 class, just employers are struggling to figure out how they're going to pay for that. They some of them think this is the greatest thing since sliced bread. Others think, I don't, you pay for that yourself. It's not my problem. Kind of what Teresa was saying earlier. that you hear like, hey, listen, you want to lose weight, God bless. If there's a strong connection to kidney disease, it's all the more reason to figure out how to do the math on that so that we can help employers or maybe policymakers think about how do we encourage more people to get ahead of the problems that lead to this devastatingly large budget hole that it creates when people go on ESRD and eventually need transplants. That fixed star of like, boy, Medicare we're all taxpayers paying a fortune for the end result of all of this, hundreds of billions of dollars of care, less productive people. We have our arms around that, but it gets back to this question about prioritizing and making sure that we're not inadvertently creating obstacles to the things that are layups. You hate to miss the low-hanging fruit. Like, I think I saw something like 1 out of 8 Americans is on a GLP-1. Are those the same 1 out of 8 that are going to have kidney? How many of them are the right ones to make sure we're getting? I mean, maybe everybody should, but I just don't know that we've done that analysis. So those kinds of interconnections between the health interventions that we are funding and aren't funding, and thinking about how that all flows through to kidney disease, it's just you can't find something with a bigger pot of gold at the end of the rainbow in taxpayer land in the Medicare program. You just can't. And everybody would like nobody to be on ESRD and on dialysis, and nobody to, everybody's rooting for the same thing. We have these like weird obstacles we built for ourselves that I think just can be illuminated with better analysis, better data.
Thank you so much. That's a great answer. I think it's so interesting. You mentioned GLP-1s. I think the fact that, I think we're just learning all the things that GLP-1s can do, and that there is an on-label use for, at least for the Ozempic or the Novo Nordisk drugs. There's an on-label use to use it to treat chronic kidney disease. And so, what's that overlap, like you said, of people that are on the GLP-1, but they also are maybe also their kidney disease is being impacted in a positive way just by being on it for weight loss. I mean, I think there's so much we don't know about GLP-1s, and it seems like there's real promise there for a lot of different diseases. But yes, there's just a lot of a rows to hoe here, and more information that needs to be gathered. So I just want to, first of all, I see that we've got some ACAF ambassadors on the phone on this call. So thank you so much. Appreciate everybody for joining. We do have some questions from the audience, and I certainly encourage others to ask a question. So one of the questions is that the entity spending the money to lower costs is not always the same entity that saves the money when we reduce cost. Which is why obviously fiscally sound maneuvers don't happen. So how does this new legislation address that problem? So I would say that this legislation is designed to do just exactly that. It would, right now, the Medicare program does not have a mechanism to share savings with private entities. It can share savings with within the Medicare and Medicaid programs. But this is a demonstration program that would, for the first time, allow Medicare to share savings with an entity that can demonstrate that it has saved Medicare money by slowing or stopping the progression to end-stage kidney disease. And so I think it's absolutely right. I think one of the strongest incentives that we have in our healthcare system are costs. And if you don't address how much something costs, or you don't address sharing savings with an organization, with entities, then you're not really going to move the needle forward very much. So that's why we think this legislation is so important, is that it opens up that discussion of, if you're going to invest in upstream care as a private entity, as a private employer, a private insurer, you're saving Medicare money, but you don't see any of that savings. And how do we address that challenge? And I don't know if any of the panelists have anything they want to add to that.
I mean, I can just talk in a general way that it's not unique to kidney care that there's this misalignment of you want the people to invest, and they're really not necessarily the ones that are going to get the full benefit. my work suggests in this case, they actually do get a lot of benefit. I mean, just from a productivity standpoint. And so they may not understand that they could get that benefit. And so that's part of the challenge. There's always this issue about, like I always use the example in my class, like if you had a vaccine for Alzheimer's, but it only worked on your 64th birthday, what would happen? You'd love for Medicare to pay for everybody's, but none of them are in Medicare because they're 64. And so there's just this huge misalignment. There's all kinds of interventions that you would like employers to make in a 55, 60, 62-year-old that'll pay off in Medicare big time. That is an issue in our system. The demonstration projects and the legislation that you're talking about could be great models for some of those other areas where you're trying to create the right framework for the employers to really, be properly motivated. So whether it's with information or incentives, and I think that's really got to be the goal.
Thank you. Teresa, did you want to add anything? Okay.
I mean, I can jump in, Holly, and just say that I agree with Neil in that I think if I think about this, when you think about the sort of investment versus the return on investment equation with prevention with an employee, and then let's say they go somewhere else, right? Or that's always an issue, like you said, Neil, of any sort of chronic disease diagnosis and management for a worker and the employer. What is that return on investment? I think the CKD population and ultimately the ESRD population is a little different. To your point, Neil, you can almost test this premise on this because you can't, by way of having the ESRD diagnosis, you then become eligible for Medicare, right? So you can see, I think, a more direct connection between the employer deciding to offer the screenings and the prevention tools and services. It can be measured a little bit more cleaner, I think, than maybe other disease diagnosis can over time for the employer. So I think this is going to be a very important shared savings program, not just because it's going to generate savings for the taxpayer and Medicare and for employers, but I think you're right that it's sort of a captive experiment, if you will, that this is something that, something that I think we all in health policy world battle all the time, which is how do you assign a value or factor of savings to upfront chronic care management, prevention, all of the things, because you never get the full credit for that when it comes to a straight like Congressional Budget Office score. And so the more we can test some of these direct cause and effect in terms of savings, I think the more that can be replicated.
Yeah, thanks, Melissa. That's a really great point, too. I think when you're talking about legislation and moving things through Congress, you have to get going to the Congressional Budget Office and getting a score you really can't move ahead without that. And the CBO has been very reluctant or won't really take into account future savings that would be realized through prevention. And I think, that's something that many members of Congress over the years have really pushed back against. And so that is a challenge that has really stymied people from getting certain things done and getting things introduced and moving forward. I see a comment from David Manis as all successful prevention appears to have been unnecessary. I'm not sure I understand exactly what that means. I would say that I think preventing and slowing the progression to kidney disease really shows enormous promise because you can now slow the progression with medication. I think the real challenge is getting people diagnosed, getting them to the right providers, which, Neil, as you mentioned, can be enormously difficult for people in underserved areas, and then getting your insurance company to cover what your doctor has prescribed. And so I'm not saying it's easy. There are certainly huge roadblocks in the way for people. But oh, I see. Prevention doesn't get credit. Yes, that is correct. So prevention does not get any credit for its success. 100% correct, at least when it comes to the Congressional Budget Office. But I think that's what keeps many of us in this kidney space going, is in the chronic disease space, is that there are treatments. It is super cheap to diagnose people. The rest of it maybe not so cheap, but there's enormous promise and possibility here. So Neil, if you want to answer another one of the questions in the question box.
Oh, sure. I'm happy to. And thanks, David, for all your really good questions, by the way. So I can't go through each and every one. I would note a couple of things about, I was curious about your telework. The assumption is that it maintains or improves productivity, and employers have dragged everyone back to the office. And so employers don't care about productivity. That's like hard for an economist to hear, because economists think, well, employers probably have some idea about what makes people the most productive, and therefore implement policies that are trying to do it. But that would be in complete contradiction to my comment about their interest in doing preventive care for kidney disease in the first place. So employers may or may not be so good at knowing what's good at any given time for productivity. The market will eventually tell them as their stock goes into the gutter or they go out of business. And time will tell on telework for various industries and everything else. I think that it's a good example where there's some lack of data and a sound experiment to see where the ROI really is on all of these things, whether it's telework or anything else. They tend to make these big decisions. And it's always easiest to sort of like put off the prevention, and really that's a mistake. And so the numbers suggest that it's a mistake. And I don't know the answer, by the way, on your question about whether the underlying cause that led a person to ESRD. In my analysis, it doesn't. Like once they're in, all I'm looking at is the CKD folks. So we're capturing their diabetes costs, their hypertension costs, because those go along with CKD, but we're not doing anything causal. So I wouldn't be able to answer that. And then your point about disparities can make innovations worse before they make them better is an excellent point. I'm just going to agree with. And the GLP-1s are the perfect example, where I'm sure if you look at the income distribution of who's gotten access to those, I'm sure there's an income skew.
Mm-hmm.
So
Yep.
hopefully I got a few of David's good questions.
Thank you, Neil. Well, we're getting close to the end of our webinar, so I just want to thank everybody for joining today. Really appreciate the good questions, and really appreciate the panel. This group came together back on Capitol Hill in May to have a briefing, and we thought it went so well and the conversation was so good. That's why we're here again today. So before we leave, I just have a question for each of the panelists today. So for Teresa, Melissa, and Neil, I'd like each of you to share briefly what's one change, whether in policy, employer practice, patient engagement, patient education, the sky is the limit, on what could have the biggest impact on preventing chronic kidney disease progression over the next 5 years. So Teresa, I will start with you.
My thing is knowledge is power. I think education is still the baseline for all of this. We have so many people at all different levels, to the minorities, the Blacks, the people that are working in blue collar workers, up to the CEOs of these hospitals and CEOs of insurance companies, even physicians that don't know what to do with somebody when they have this, stage 2 CKD come up. Employers can, we talk about just doing the urine test, but they can do education. A lot of them send out like monthly little emails, like with different things, and a lot of them have your health, and they talk about blood pressure and getting exercise. Well, they can educate about kidney disease too. It's so prevalent. It's not some rare disease that very few people are going to have. There are very few people in this country. I rarely come across somebody that when they find out I had a transplant can't tell me someone in their family that has gone through or is in kidney failure, whatever. So for me, it's not just doing the testing, it's educating as well. And I think getting the word out and educating is still the power. It's the wheel to the cog that would make everything go. So I feel like education is just huge.
Thank you. Thanks, Teresa. Melissa?
I don't know what Teresa said. I'm kidding. No, I mean, I think it touches, I think I would say probably following on to Neil's previous comments, I think actually this bill and being able to demonstrate empirically an ROI for employers to understand the value of the screening, and in addition to really understand how this could be applicable in other disease states, I think could really be very beneficial, because I think, and maybe it was Neil who was mentioning this, but when you mentioned the GLP-1s, for example, if you've seen one employer's benefit, you've seen one employer's benefit. I mean, that's the beauty of being a large self-funded employer benefit plan under ERISA, is that you have a lot of flexibility to design the benefit plan, right, around the needs of your particular workforce. And so things will vary, right, depending on how they want to spend those health plan assets to address the healthcare needs of their particular workforce in any given state or region or nationwide. So I think the more evidence, like with this, hopefully this shared savings model will do, that can be sort of evaluated by more uniformly by employers, I think will make a difference. I also think that when we think about return on investment, and this is something that I think a lot of employers right now are trying to think through, and again, there's no one solution, but this is touching on what Teresa mentioned, which is the impact on the families of the workers. And there is a caregiving issue in America right now that employers are very attuned to. And again, every employer might choose to address that differently, but when people are patients themselves, they need the support of their families who may also be workers. When people are the family members that have to take care of their loved ones at home, you have issues with, presenteeism and, absenteeism and all the things from retention. So really looking at this comprehensively in terms of what could be ultimately the savings in its entirety, I think would be helpful when you actually factor in the impacts of the families who are working too on this. So I think this is a great opportunity for employers to really lead the way.
Thank you so much, Melissa. So in our last 2 minutes, Neil, we'll leave you to close us off.
2-word answer: more webinars. That's it. We need more webinars. No, I really do think what we need is education and information. And just having done this kind of work now for the last couple of 3 years with you guys, I just always think I'm going to go on the internet and these answers will be obvious, like how much can employers save with kids, and it's not there. And so we need a concerted research effort, an educational effort to really paint a picture in a way that CBO, for example, can understand. In order to get CBO to pay attention, I used to work at CBO, you need published research. You can't just wing it. You need peer-reviewed stuff that demonstrates the kind of cost impact. And there's just not as much of that as you might think. And so, I mean, there's very little. So they don't have much to hang their hat on and to do a good cost estimate. And that's really the gating factor. So that's where I would, that's my opportunity to contribute something.
Excellent. Thank you. Well, again, thanks to the panelists. You guys are amazing. And I also want to thank everyone. I want to thank NMQF for having us and for everyone who attended today. Thank you so much. And we hope that people are walking away with a little bit more knowledge about kidney disease at the end of this conversation. And we hope to continue this conversation in the future. So thanks again, everyone.
Have a great weekend.
Bye.